Thank you, Anil, for the introduction, and I really enjoyed the talk on the telemetry. I think that's definitely overused and important to save our resources. Can you guys hear me okay? Okay, all right. Let me just figure out the system here. Okay. Um, so today's talk, it's an interesting talk. So there's a lot of data, so I may have to skip through some, but I'm gonna walk you through a patient that we typically see in clinic and just walk you through that whole process and take you through the journey of how we manage atrial fibrillation as of today. Things are evolving in cardiology, in medicine, EP especially, because it changes like every 3 or 4 months. Just like your new iPhone comes every 6 months to a year, things change very quickly. And so what you knew, say 6 months ago, it may not apply today. So I'm giving you a more up-to-date information. What if I saw this patient in clinic today, which I probably did something like that, what I would do. Okay. So I have no disclosures. So this is Ruth. So it's not information that's protected. This is Chat GPT generated Ruth. So just put in Ruth and you get 80-year-old female with atrial fibrillation. Her name is Ruth. So Ruth came and saw me in clinic. She's 80 years old, has a history of high blood pressure as well, and usually fairly decent health, and was found to be in atrial fibrillation with heart rates in the 130s, 140s. They started on metoprolol. She's like, I'm pretty active. I have a very, very busy social life, and this is impacting me because the metoprolol makes me tired. The AFib makes me like upset because my heart rate's fast. I just need something to do for this. And what else do I need to worry about? So, and then we started talking about various options. I said, okay, let's figure out how much AFib you have. Is it paroxysmal AFib? Is it persistent AFib? Because the treatment options change based on the type of AFib you have. So we have Holter monitors, and then we have like event monitors and MCTs. We tend to do a lot of MCTs and events from the hospital side, but also from the clinic side. If you need more information, if we know they're having AFib every day, you just need like a 3-day Holter or 7-day Holter, and you'll be fine to get your AFib burden. But these days, the MCT and the event monitors are able to give us the burden as well. So if you need longer monitoring, we can do that. So we did that. So we did, like she said, I need to get things done fast. So we did a 3-day Holter. And this is from Preventice. This is what we have in Legacy. And we can extend the Holter up to 21 days, are typically 14. Anything more than that, you need like prior authorization from insurance. But MCT is another option that if you need longer continuous monitoring with alerts. So Holters don't give you alerts in the sense that if the patient has a Holter and something happens, we will not be notified. But if they're on an event or an MCT, something happens, they call the patient, ask them, are you okay? And then they notify the physician on call who has ordered the Holter, and then we can act on that. Sorry, ordered the MCT or the event monitor, and we can act on that. So that's the difference between those, and the duration as well can go up to a month. So Ruth had that, didn't have too much information from that, no AFib, but she is saying that, hey, I know I have AFib, I just didn't have it this last week, but I need to know something else. I need to know when I'm in AFib, I need to have the best course of action. So then we decided to do an implantable loop recorder. So we've done our initial assessment with a Holter or any other monitor, and now we can do this implantable loop recorder. It's a very simple surgical procedure. We insert it by making an incision of 0.5 centimeter left of the sternum, inject it, can last up to 4 years. It records every single heartbeat, and based on the parameters, it sends us information on AFib or PVCs or VT or whatever is happening, pauses. So we did that, and so in about a month later, we found an episode of atrial fibrillation that was lasting for about a day. And we called Ruth, and she's like, I'm not feeling well. This is exactly what I was telling you. I feel horrible. And so based on her CHADS VAS score, this was the episode of AFib that we found. So based on the CHA2DS2-VASc score, she met criteria for anticoagulation. So we started her on Eliquis or something similar. And then we talked about different options. And one option was to start her on a beta blocker, which we had originally done. The other one was antiarrhythmic medications. Now, these days, if you look at the AFib guidelines, where the ablation was kind of on the lower end of your recommendation, now it's a class 1 indication, especially as of in the last couple of years, only because we've, in a center of excellence like ours, we do the most ablations in the state at the moment. We're 1,200 ablations a year. That's a lot. Starting compared to 100 ablations a year when I started 10 years ago, to 1,200 ablations is a big deal. And AFib ablations are a majority of our ablations. So we are definitely a center of excellence for that. So given that, and the fact that she's been on metoprolol, we talked about antiarrhythmics, given the risks and benefits of that, we decided to proceed with the ablation. Sometimes it depends on the insurance. They say that you need to try the antiarrhythmics first before you go for an ablation, and that we can certainly do that. But if you have a careful discussion about the risks and benefits, what's the best option for this patient? Is it safe to proceed for an ablation directly versus trying out antiarrhythmics? Based on that discussion, we thought Ruth was pretty active. Let's go ahead and do this ablation. Now, what we have done so far for the last 10 years has been radiofrequency ablation, which still happens, like more on the redo side. But our main workhorse, at least for me, was the cryo ablation that I've been doing, and I became really good at it. And I thought that was amazing. It changed the duration of AFib ablation, which used to be when I did my fellowship, and when I did my EP fellowship, I can tell you my first 6 months to my first year, it's a 2-year fellowship, every single day I questioned myself, why am I doing this? Because every procedure was at least 6 hours. Every single procedure was 6 hours. And I was like, there's no possible way, like this is real. Why did I do this? And I was a cardiologist. I was a medical director for imaging at Providence, and as a general cardiologist, and stupidly I decided that I need to do an EP fellowship. And so because it was the future at that time. I was like, okay, I need to do something different because I don't want to be like everybody else. And this was interesting for me. It was changing how things were being done, and the new technologies coming out every 6 months. So I did this. And one thing I realized is that things could be done faster. Partly it's technology based, partly it's preparation. So every single procedure that I do, I prepare for it almost like, now it's much faster because I've done like thousands, but typically I prepare for it at least for a few days before the procedure. So my homework is done before the procedure is with the patients on the table. So I don't waste time looking around thinking what I'm going to do next, on the table. I know about it ahead of time. It was pleasant. It was so nice to see one of my ex-scribes is here. He's now a new resident with you guys. I didn't know that. Time flew by so fast. I didn't realize he went to medical school and now he's a resident. And he's heard this. Do you remember hearing all this? Yeah. So we used to have these discussions with patients and prepare for this in clinic and then plan it out. And that's how the procedures are successful. Now, this is what I'm talking about today is pulse field ablation. We've heard about it. We had heard about it for years, and it was in research, and it was going to be the next big thing. And I'm like, nothing can replace cryo. It's changed everything from 10 hours of ablation. My ablation time went down to 3 hours. I thought that was amazing. Like, my attention span is typically 3 hours. It just worked out fine. And so then the PFA came out, and we waited. We were the first to be approached because we had the highest volume, but we were the last to get it. Probably a good idea because then we let everyone kind of work out the kinks, and we got it in February. And it's definitely much better. It's safer. Preserves the phrenic nerve, which is what we worried about with cryo. All the incidences were less, but that would happen. The esophagus was always an issue. Esophageal injury is an issue. Rare, but it can happen if it's an atrial esophageal fistula, which has happened here once since I've been here. Not by me, but I've seen it, and it's pretty much fatal. So those are things that we worry about radio frequency more than the cryo, and then the cryo has other issues. And then this came out, is saying that no phrenic nerve injury, esophageal injury is possible with perforation, but it's less. No pulmonary vein stenosis. There's so many other positives. The duration of the case they were describing was the whole entire procedure under 2 hours, like patient in the room, out of the room. Actual procedure under 30 minutes was unreal. We started doing it in February, got better and better and better. And definitely, it's despite, we're not trying to be fast, but it is much faster. The results in clinical trials were compared to cryo. And we'll talk more about this, but this is what we are doing currently. And why it's important for you guys to identify, you see patients in clinic or in the hospital who may be candidates for ablation in addition to antiarrhythmics, and to understand that, because you may be asked these questions. So Ruth read about this, with our friends. One of our friends had the PFA, and they're like, well, Ruth, if you were going to have an ablation, get the PFA. So she came in with these articles and said that, hey, I wanted to learn about it. And we started noticing this last year when FDA had approved it in July. Patients would bring FDA articles and say, I want this. I'm like, well, it's not here yet. And they would wait. So this is basically their whole purpose for AFib ablation is pulmonary vein isolation, no matter how you do it. And that's what we realized many years ago, about 10, 15 years ago, that if we do pulmonary vein isolation with either radiofrequency, cryo, or whatever modality that you choose, you would have the best results for management of AFib. The success rate for paroxysmal AFib cure was about 80%, for persistent was 50 to 60% with any modality. Now, again, the indications are patients who are symptomatic, refractory to treatment AFib. Asymptomatic patients, we tend not to offer an ablation unless it is affecting their cardiac function and structure. Like sometimes if you have persistent AFib lasting for years, and they're asymptomatic, but now you have left atrial enlargement, severe enlargement eventually leads to pulmonary hypertension, left heart failure, all of those consequences. So then we have to kind of stop that whole progression. So then we tend to do that, but it's mostly symptomatic that we try to offer this to. 18 years and older is our typical approach. We have a pediatric EP who comes from Orange County. He says that he does PFAs in younger kids, but we don't usually recommend that, but that's what they do there. So what is the PFAs, pulse field ablation? So what happens is that our idea is we have to get rid of the pulmonary vein potentials. Now, how do we do that? We can use radio frequency, cryo, cold, really minus 60 degrees of temperatures is what we were aiming for cryo. Now, what it does is that it causes electroporation. So if you see in the image on the right side where you have, yeah, you see the cursor there. Okay. So you see these holes. This is generated by beams of electricity, 1500 volts, just targeted to those myocytes. So when these holes are created, eventually the cell content comes out, and then you have cell death. And we're trying to target the myocytes that are right next to the pulmonary vein ostium. Those are the ones that have pulmonary vein potentials, which are known to cause atrial fibrillation. So that's how we do this. And this is the ablated tissue. It's hard to see the difference, but this is a non-ablated tissue, this is the ablated tissue. But what it does is that it spares the blood vessel, it spares the nerve bundles, and that is important for us because we don't want to damage the neighboring structures, and that's why this has been helpful. Now, the process of how a technology like this gets approved takes many, many years. First, it's presented, like they're independent companies, startups that even now they have like amazing ideas and ways to do certain procedures. It's founded, then a big company analyzes it and says that, okay, it makes sense, I think it has a future, so they buy it. Then they do trials, they have the resources to do trials. They do like multiple trials, and then they do the first device, first in human, a few years later, and then it just kind of progresses. In Europe, they had already done 100,000 patients before they came to the US, before FDA approved it. So it's been in Europe for a few more years, and that's the trend with medicine, with with surgery, with cardiology, especially because a lot of our procedures change every few months. That Europe is ahead. Now, we get a lot of complication data from them, which is helpful. We had a lot of practice data from them, but the way we practice here is very different from Europe, but it does help us. So this is how like the R&D of this catheter changed. So it started with this. Usually they have like like nitinol is a material that we use for a lot of our electrophysiology and structural cardiology procedures. So they start with nitinol material, and then they put these electrodes, and they want to deliver PFA through these electrodes. Then eventually form something stronger. They have this something called lasso catheter, which Medtronic is another company that has that. We use that as well. And then this particular one is from Boston Scientific, which is like a flower. And the idea is that all these electrodes are able to deliver 1500 volts. This is the console that we use to do that. This is a sheath that we are able to go transeptal through the intraatrial septum and get into the left atrium, and then are able to do the ablation. It's a deflectable sheath, and you can use this turning device to deflect it. And then this has a controller. It forms the flower, we call it a flower, which is able to kind of stick onto the atrium and deliver the impulses. But if you need to go deeper, then we change it into a basket. So this is another version of that, how it's done. These are different controllers, different sizes. So what they found is, so basically it's dose validation. How much should we do? Just a real quick thing. So we normally deliver like total of 8 doses of impulses per pulmonary vein. That's basically it. I couldn't play the video on this, but you're welcome to watch it online. There's a nice video for the PFA that basically shows how you get in, and then how the flower is formed and how do you apply. So this is how we do the transeptal puncture. The wire goes into the pulmonary veins, and then we advance the catheter over that. And this is an image of what happens after the ablation. This is the pulmonary veins that were isolated in that procedure. So efficacy, safety, and efficiency. Efficacy, like I was saying, our goal is to be closer to what we have with cryo and RF. Is like 75 to 80% success rate with paroxysmal AFib, and about 60% with persistent AFib. Sometimes we get the posterior wall of the left atrium for persistent AFib. We don't normally need to do that with paroxysmal. The thermal injuries, there were like 0 thermal injuries. I mean, it is a procedure in the left atrium. There is a chance for tamponade, which later on in a clinical trial, I'll show you that it is there. It's equivalent to cryo and PFA and RF, but it's also operator dependent. As the technology is new, the chances of complications are slightly higher as people get more comfortable and used to the technology and how to move it around in the heart. The complication rates go down. So some of those data is from the initial study, but I can tell you for a fact that I've done maybe close to 100 now, since we do about 4 a day on my procedure day. And as I do more and more, I definitely get much, and I'm always very paranoid about safety. So given that and how fast it goes, things are going quite well. So the actual ablation time for pulmonary vein isolation now is under 20 minutes. I did one case yesterday, pulmonary vein isolation and the posterior wall, which normally would take 3-4 hours if we had to do posterior wall. It's like total was under 30 minutes. And the entire procedure in and out was under an hour. So that happens. That's not the goal, but that can happen if everything goes as planned. So again, these are the different companies that manufacture the PFA. For your standpoint, like 75 to 80% success for paroxysmal, 60% for persistent. The goal is the same for them. Now, this is a kind of a busy slide, probably not a great backdrop, but basically the phrenic nerve injury is 0 in this. In cryo, we used to see that some of it. And then tamponade, they had some in this study, which was about 0.7%. We monitor that very carefully. We have an intracardiac echo that monitors for tamponade as well. I'm being cautious with time. Are we here till 1:15 or 1 o'clock?
1:15 is
okay. So I'll try to finish by give you 5-10 minutes to ask questions. With the cryo, we used to have gastroparesis as well, but with PFA we haven't seen anything. Pericarditis was extremely common with RF and with cryo. Like almost every patient had pericarditis, and we would empirically start them on colchicine, which is great for pericarditis. With these patients, we've found like less than 1% patients have pericarditis. A lot of them are same-day discharges now. So out of the 4 cases I did yesterday, 1 stayed back. 3 of them went home. So that's great for the hospital bed situation. And then the patients tend to do well. And we didn't start that. So it's been like February, 3-4 months of trying it out and noticing how patients do. Then we did that. So you're going to see some of that. This is again another study showing the different complications that can happen. Again, it's a surgical procedure, so there could be complications. Just have to be careful. Now, what we do is important for you guys to understand is that how we prepare a patient for an AFib ablation is that they are on full anticoagulation until the day of, or the morning of the procedure. And then we do something called an anticoagulation time to see what it is, and we try to keep it over 300. Because if you're working in the left atrium, your chances of stroke is pretty high unless you're anticoagulated. Overall stroke risk is under 1% in general from multiple clinical studies. So we keep it that way. They go back on their Eliquis or whatever they're on that night. So that's we keep them pretty much fully anticoagulated, give them heparin during the case. So Ruth had the PFA. She did well. She did really good. She was kept on Eliquis a month before and up to 3 months after. But after 3 months, she started saying that, hey, I'm having some bleeding, bruising. I fell down. I couldn't stop bleeding, and my entire life is being affected. I can't go out anywhere. I'm scared, so I don't know what to do. And so we talked about different options. Ruth was 80 years old, but she did weigh about 75 kilograms or so. And so she didn't meet criteria for the lower dose of Eliquis, which is basically age over 80 and your weight less than 60 kilograms, and it's not or. And so she didn't meet criteria for that. We know function was good. So we talked about the Watchman. We've done it now for about 10 years. Thousands of patients in legacy, good results, comparable to warfarin. A lot of these anticoagulants the studies were compared to warfarin. And so basically it's non-inferior. All of them are designed to be non-inferior unless someone does it independently, but nobody else has that much money except for drug companies to do it independently. So they're all done non-inferior because they know that they can get approved in a non-inferior way. But in real world, things either succeed or fail. Watchman's done well. And there are many different companies that are manufacturing it now, but none of them are approved. And we have the most data with the Watchman and the most success. So we talked about it, and so what we need for the Watchman is a shared decision making. So me and Ruth agree that makes sense. Her CHA2DS2-VASc score is like 3 or more. That's the criteria for the Watchman and indication, appropriate indication. But we need one other physician to approve. So her primary care doctor or her cardiologist, referring cardiologist, needs to agree that yes, this makes sense. If you don't have shared decision making, you can't proceed for the Watchman, and this is just to prevent unnecessary implantation of devices. So we all know this. AFib is a major cause for stroke and debilitation. So even though someone's had an ablation, doesn't mean that they can be off of anticoagulation. So we go off of the CHA2DS2 score or the CHA2DS2-VASc score and determine their need for anticoagulation. Now, if someone is under 50, they've had an AFib ablation, and their CHA2DS2-VASc score is say, just for the sake of discussion, is like 2 for hypertension or something else. can they be off of anticoagulation because they're young and we've done their ablation, and what are their chances they're going to get AFib back? It's interesting. So I typically continue anticoagulation for 5 years for those people, and if they've not had any further AFib for 5 years, then I put them on baby aspirin. Now, there's the consensus on that is 50-50. So in Europe, they have a study, that's the only study where it's a prospective trial, no, retrospective trial, where they said that it's 50-50. It's up to the physician to make that decision. But hopefully we'll get some answer. If a young person gets an AFib ablation, do they need to be on anticoagulation if their CHA2DS2-VASc is 2 or above? If there's less than 2, you don't need to be. Baby aspirin's fine, or even nothing. That's what the guidelines say, but I typically keep them on an aspirin. Hard to give up aspirin when it's been used for like 30-40 years. But at least came down from 325 to 81. Dr. McAnulty still does 325. So I follow Dr. McAnulty blindly. So, this time 325, 81 compliance, like, and the guidelines are saying nothing or 81. So I went with 81. So now in the heart, the left atrial appendage is a dependent structure. And this is where the blood clots collect. So on this side, this is a dissected model. You see the thrombus there. On a TEE, this is where the thrombus is going to be seen. So almost majority of the thrombus in the left atrium gets deposited in the left atrial appendage. Unless you have an LV thrombus, if you have an apical aneurysm in the LV, then yes, it'll get thrombus deposited there. But otherwise, it's the left atrial appendage. So the surgeons typically, what they do is when they're doing an open heart surgery, they clip the appendage. Like either if the surgeon is very thorough, what they would do is they'll cut it, they'll sew it, they'll make sure there's no gaps, there's no like pockets that are there, and then with those surgeons, I'm really happy, and then I do take them off anticoagulation if they do it. But majority of the time, what I see is that there's like a little knob or something like a pocket that's left. It's enough for the blood clots to get collected. So I still keep them on anticoagulation unless I do a TE to confirm it. These days they have something called an AtriClip that the surgeons do. That's been okay, but we still have to make sure there's no pouch that the clots can collect in. So the Watchman, what it does is that it sits inside as long as there's no thrombus, and then I'll show you some of that in a second. And that helps with healing of, so basically an endothelial layer develops over the Watchman over 6 weeks, and we see that in PE. And then like if say the left atrium, if they're in AFib and they're not contracting, or if there's damage, if there's like severely dilated, because the heart's still pumping, there's a nice smooth space for the clots or blood to kind of go through, rather than a dependent area where they can sit down and form thrombus. So this is basically the CHA2DS2-VASc score. You guys know all this, so I don't need to kind of go over this, but yeah, so the indications for a Watchman is like a CHA2DS2-VASc of 2 in men and a 3 in a woman. Same indication for anticoagulation. Ideally, if it's in a man, a CHA2DS2-VASc of 3 puts them in an easy approval status with insurance. Otherwise, there's a lot of back and forth. And here's this one's an interesting slide. So with no warfarin, this is your risk. So let's look at CHA2DS2-VASc score of 4. So it's like 1 to 1. A 4% 4 score and a 4% risk. It goes down with aspirin to 3.1 a little bit. So if they're really resistant, maybe at least aspirin. And then 1.4 with warfarin. So Watchman the goal is to be as good as warfarin. Hazlitt score also helps us in our decision making, like what are the risks for major bleeding, and then that also helps us kind of discuss the Watchman. So the bleeding risk compounds over time. So if the annual bleeding risk is like 4% or 5%, over time it just compounds. So if you look at a Hazlitt score of like say 2, and your bleeding risk is 4, and then a 10-year risk goes to 34. So you think about that as well, is that, okay, now it seems like it's not so bad, but in 10 years, what it would be. So those are some things you have to think about. Again, it's not an individual decision. It's a group decision with the patient and the referring doctor as well. Their risks of anticoagulation, then like bleeding, daily regimen adherence is a big issue. Patients with warfarin, even on DOACs, they miss their doses and they can be at a high risk for stroke. And so that's another aspect that we have to think about. So with the DOACs, the compliance rate has definitely gone up. With warfarin, it was kind of on the lower side, but the DOACs, as we're seeing the compliance rate kind of going up from 50, 60% to about 70 to 80% in some places. It's still a challenge to maintain adherence to anticoagulation. Nobody wants to take it, but we do recommend that. We have great anticoagulation clinics, but for some patients who are higher risk, watching is definitely an option. So these are some things that you guys can look. So now it's instead of a class 2B, it's kind of moving up as a class 2A indication. It's not a class 1 indication yet, but for some patients, it is a good option. So this is how we do the Watchman. Again, transeptal, just like we did the ablation. Put the Watchman in. This is an older Watchman with the nitinol mesh. The newer one is more flexible. It's much easier to use. And we send the patients home either the same day or the next day. So this is important. So what do we do? So when a patient does need a Watchman, that doesn't mean we're going to be off of anticoagulation right away. So what happens is that we want them to be on anticoagulation a month before, get the Watchman. Either we can continue the Eliquis just for the sake of saying Eliquis for the next 6 weeks, do the TE, make sure everything's okay, no thrombus, then switch them to aspirin and Plavix like that for a total of like 6 months post-implant. And then you go on to aspirin 81 milligrams daily. This is the recommended therapy. Now the other one is a more like shorter therapy is like 6 months. So you can just go to DAP right after implant, and total of 6 months, and then aspirin alone. Now, we in Legacy, because Dr. Desai started the program, I do the Watchman as well, but I tend to follow the rules a little bit more. So Dr. Desai, he had the most experience with Watchman, so he had his own panel of patients. Now he's got like several thousand now, where after the 6 weeks are done, he goes directly to aspirin 81, which is good for us because we have our own data that we've collected and submitted in many trials and studies. So which is good. If you need to fall back on that, it's great. But I try to follow the guidelines set by the company to do at least a total of 4 to 5 months of DAP after the 6 weeks. At any point, if the patient's not able to take it, I switch to baby aspirin because we have that data. Now we are going to be in a trial. We are in a trial called Simplify, which I'll mention it later, where you can have DAP and you can have monotherapy. It means that you put the Watchman in today, tomorrow they can just be on aspirin. You can stop the Eliquis right away. So that's like a randomized trial. You can go in either arm, and so we'll have more data on that. So the world is moving towards monotherapy or shortened DAP therapy. So we were ahead of that curve in Europe. That's being done. So, but for now I'm still following that, like 3 to 4 months of DAP after 6 weeks, and then aspirin. Just letting you guys know it doesn't stop right away unless you're in a simplified trial. So this is 2015. You see the fabric. The fabric prevents thrombosis. Fabric got extended a little bit further, more flexible, less sharp. Results were great. And now this fabric is all the way down. So the chances of thrombosis, post-implant thrombosis, is much less now with the Watchman. Easier to use, more patients can be helped. So Ruth got the Watchman. She was happy. She wanted to go home the same day, so we sent her home. And then 10 days later, she started going back to her daily activities. Saw her 6 weeks later. TE was great, no thrombus, good positioning, and these are the different sizes. And she was okay taking aspirin and Plavix for 3 months, and then aspirin alone. And so she did well. So these are some of the trials for the Watchman, just for your reference. Patient selection, we talked about. Yeah, so this is a nice slide, simple way. Drug interactions, like if they have arthritis, taking a lot of NSAIDs, they can't be on it, NSAIDs because of the Eliquis or something. or warfarin. They're bleeders, future bleeders, high risk, high fall risk, non-compliant, they just don't want to take it. Lifestyle, like hobby, daily activities, is affecting them, making them depressed. That's also an indication. This one needs to be explained a little bit more, obviously. Most insurance companies cover it now. And they have a lot of resources, a lot of support from the company itself, as well as American Heart Association, HRS, to guide them. And different trials. Let's see, this one is Champion. This is a simplified trial that we are currently enrolled in, and these are further other trials. Okay, let's see. There we go. All right, so I'm going to pause here. I know I went a little fast at the end, but any questions? No?
Can you comment on management of asymptomatic device detection?
Yeah, that's a really good question. That's so typically for clinical trials, what is sustained AFib is 30 seconds. But if it's a device detected AFib, in the studies that we've had before, it was 6 minutes of AFib needs to happen to be significant to put someone on anticoagulation. Now it's gone down to 3 minutes. So if it's on a loop recorder, pacemaker, 3 minutes of AFib is enough to start anticoagulation. Depends on the overall risk for the patient. If the CHA2DS2-VASc score is pretty high, I probably would even start it at like 30 seconds to 1 minute mark. But if the CHA2DS2-VASc score is low, like under 2, then I would follow the 3 minute.
And
Yes.
extending on that, could you comment on personal device? So Apple Watches, the cardio monitors, like what you do with patients that come in?
Yeah, so those you cannot detect. You don't know how long the duration is because they only get 1 minute of data, and so it's hard to know. What we tend to do is we follow it up with a regular monitor like a Holter or an NCT. But it helps with post, once you know that someone has AFib, and then you're trying to figure out, like, okay, how are you feeling? Show me if you had more episodes. That helps with post-procedure or post-medication management and titration of medications as well. So yeah, in terms of Apple Watch and Cardia, and multiple other companies make the rhythm now. It's like Google and then Samsung. So all of them are fine. Cardia has 6 lead as well, which can also detect MI. So that's also a good option to have more. So yeah, we use that a lot. Yeah, almost all of our patients have some sort of a personal device. Yes.
How often do patients require repeat ablation? And if so, how soon after is safe to ablate the patient?
It's also a very good question. So if it's persistent atrial fibrillation, is like 40% of the time they need a second ablation. Paroxysm is like 20% of the time. I typically like to wait for 5 to 6 months because there's even though they're not having symptoms, we know that they have pericarditis and there's inflammation in that area lasting about 3 to 4 months. Think about it this way. What we do for the AFib ablation is exactly like the MACE. It's basically the MACE, but we're doing it endocardially. MACE is epicardial. And the same, the heart doesn't know it had open heart surgery, so we're working on it more than the surgeons do actually. So it's a lot more inflammation. So it goes on for 3 to 4 months. Like for post cardiac surgery patients, you tell them take it easy for 3 months. You have sternal precautions, but the heart's also healing. Same thing. But the only difference is you go home the same day. You may feel good, but the heart will. I tell patients the heart will take about 3 months to heal. Yes.
If you map the site of AFib, is it from the same site that you ablated, or is that from a different site?
So one important thing to understand. So when you're looking at any kind of rhythms, so you have triggered, reentry, and automatic rhythms, right? So most of these rhythms are one circuit. Or if it's a spot, like a triggered spot, it's one spot. AFib is millions of small little circuits. So it's like diabetes. It takes over the entire heart pretty much. But we found the origin to be in the left atrium. So there's no way to detect where the AFib is coming from. So to your question is that, are you talking about redo?
Yeah, exactly. But
calculate in one place is your, when you map it
Yeah.
in sweep, like, are you getting the same origin or are you getting a different?
So origin, you can't tell. So the only thing that we can see if it reconnected is, like say, for example, we do pulmonary vein isolation, right? So that's our main thing for AFib. Now, when we go back, we're looking to see if it reconnected. Yes, so we're looking at signals from the same area that are we seeing PD signals again? Did they come back? So we get rid of them again. Now, if we do the posterior wall or the roof or the floor of the left atrium, we try to see in that line that we create from the right superior to the left superior pulmonary vein or the right to left inferior pulmonary vein, is there a break in that line? So we, with our mapping catheter, we kind of follow that line to see if there's a gap somewhere, the signals came back, and so we clean that up. So that's how we see, but we can't see the AFib origin. Other rhythms, yes. In this one, you just can't. You're just going off of probability data. Yes.
Is the wait time for a repeat ablation similar with the pulse ones? Because I know you noted that there was a lower incidence of pericarditis. So are you waiting for a shorter amount of time?
No, the inflammation is still the same. So I mean, at least at the moment, I'm still waiting 5 to 6 months. Two reasons. One is I want the inflammation to be completely gone, before I go in. Number two is it's also mentally troublesome to the patient that, hey, I just had this ablation and I'm going back into AFib like 3 months later. So we started the discussion, gives them some time to kind of come to terms with that, saying that it's a tough disease to get rid of. But it just helps them when I give them about 6 months, unless something else is happening and they're really, really sick. Yes.
Are we moving towards like going away from cardiac ablation, or is that still kind of like first line treatment?
No, so cardioversion is it's a quick fix. It doesn't treat anything, but what it does is that it gets you out of trouble at that time. It's going to come back again. So we still do a lot of cardioversions. So if it's persistent AFib and the patient's symptomatic, we try to do the cardioversion, like either medications or medications plus cardioversion, the first time to get them out of it, and mainly to see how long it takes for them to go back into AFib. It's guaranteed they're going to go back. It just matters when. That helps with ablation planning as well. So it's say, for example, the cardiovert the very next day go back into AFib. Then we're like, okay, this is going to be a tough case, and we tell them that you may need more than one ablation because it's going to be challenging. So paroxysmal, there's no point doing cardioversion because they're paroxysmal, they're going to go in and out of it. But yeah, it's still there. It's just not as a curable tool. It's more of a temporary fixed tool. Yes, sorry.
From like the primary care standpoint, what can we do before they get to you to like set you up for success?
Yeah, no, that's a really good point. So we have a workflow that we created for primary care. That was like 7, 8 years ago through Nick Cashy. I don't know if it still exists, but basically it included all the things that you need to do, like include discussion about anticoagulation, making sure that you understand the burden of atrial fibrillation, start to talk to them about ablations, and educate them. I think education is the biggest thing. Rate control agents, antiarrhythmics and stuff, leave it to the cardiologist. So the typical process is that you do your diagnostic workup, start the education. You can get an echo, you can get a Holter or whatever. Send them to general cardiology. It doesn't have to directly go to EP because they may not be ready for an ablation. So go to general cardiology, let them kind of assess everything, make sure nothing else is happening. Then they would send us to EP, unless, like say, you're one of those astute primary care doctors. We have quite a few in Legacy who actually I prefer them sending me patients than a cardiologist because they do such a thorough job. Dr. Hendon is one, there's a few others, and they're just amazing. And to the point that if I respond to their patients, like the patients send me a message, a common message, and I respond, he texts me saying that, hey, can I take care of this? Like, please don't respond to my patients. You know? So he's really good. And
He's retired.
oh, he's retired?
Yeah.
Oh, yeah, no, he's amazing. There's quite a few like that here in Legacy, luckily. But yeah, so if you can do all those things, send them to cardiology and then come back. But if you are comfortable understanding that, okay, they're ready for an ablation, then you can talk to me directly or Watchman. Watchman's a good one because it doesn't have to go through cardiology. If you guys feel that this person's high risk for anticoagulation, like bleeding or fall risk or whatever, you can approach me directly and then we can kind of go over things and then, set it up. So that's another good way to do this. And if you guys want, I can have information sent out to your clinics, not only for ablation, but also for Watchmen, just so that you have it. And I mean, there's a lot of resources, but just that's a good thing. If you are able to do all of that, then it helps us. Right, so exactly on time, 1:15. But feel free to text me, email me, call me, and we are also setting up rotations for the residents. It's like kind of unofficial. Dr. McEnulty is still the best, but if you guys want to, by the way, I have to leave you with this. I've known Dr. McEnulty for almost 20 years. He's never sat down with me for coffee or taught me how to read EKGs. And I'm so jealous of you guys. Like when you work with him, you meet with him for coffee and he shows you EKGs and tells you all these things. He's never done that with me. And I told him, like, please, like, I need to do that. Just a bucket list thing in my life. Yeah, he's there. But if you want to experience like inpatient and like all this procedural EP, then feel free to reach out to me. I'm gonna leave it